Okay. So this set of slides will be on the website as a template for how you would structure a review of a paper. And so if we look at the title, it's Outcomes of Anatomical versus Functional Testing for Coronary Artery Disease. And anatomical, meaning if we have a very precise picture of the coronary artery, that is with something like CTA, coronary CT, as we saw in that slide in the nuclear medicine part, we can see those lesions quite accurately and with great sensitivity. So is it beneficial to find those lesions? And if it is, probably it's on engineers to develop CT scanners that can see them more clearly. So you push the resolution as opposed to pushing the functional estimate you get out of a CT scanner. Let's push the scanner to get higher and higher resolution, better, clearer pictures of the coronary artery. SPECT, on the other hand, which is in this paper called functional testing, looks at the flow and it says, I'm never going to see the coronary artery with my SPECT scanner. It's just too small, but I will see the flow. Is that a better thing to observe? Maybe I don't care what the coronary artery looks like. All I care about is downstream, is it affecting this patient's flow? There's an argument to that, right? That functionally it's what you care about. Not, I don't care what it looks like. Is it working? Like, is there flow happening? And so the purpose, when you read the introduction, you restate what is the major purpose of this paper? Why are we here? What are we doing? And we want to answer the question, are there fewer major adverse events, that's called MACE, major adverse cardiac events, in patients who undergo cardiac CTA versus traditional stress testing? So you come in and you have a certain probability of having heart disease. We're going to send half the patients to CTA, half the patients to traditional stress testing. And the benefit we're going to look for is, are there fewer events, right? Are there fewer heart attacks in the CTA arm than the traditional arm? The expectation here, when you're setting up this study, is that you are going to have a certain number of events, because we're going to have, say, 10,000 patients total. We know the overall event rate in this population, so we expect to see a certain number of events. And then the whole trial is designed around that expectation. And the number of patients you do in the trial is designed around that expectation, right? Because we need to see events in order to determine a difference. It turned out in this paper, as we'll see later, there was a bit of a surprise in terms of total number of events in this group. So, as we'll see as we go through this, this paper showed that there are the same number of major adverse events in patients who underwent cardiac CTA versus traditional stress test. There was no difference in the number of events that occurred. But they were only tracked for 18 months after the original visit, right? So they weren't tracked out for 5 years to see if events build up. They were just tracked for 18 months, which is a bit of a weakness. The other thing was many fewer than originally expected in each group. So there were way fewer events than they thought they were going to see. The other take-home message was CTA reveals coronary artery disease with much greater accuracy than stress testing. So you can detect who has coronary artery disease much better with the CTA. Okay, so those two things don't, like conclusion 1 and conclusion 2, don't seem to be commensurate, but it turns out they kind of are. So the way they designed this trial, and it wasn't a cheap trial, they took 10,000 patients, right? They interviewed probably many more than 10,000 to get in the trial, but 10,000 went in, approximately. 50% women. They all were symptomatic. So they had chest pain or they had shortness of breath. And that's an important feature of the trial, because that elevates the risk that you're going to detect coronary disease. You don't want to just take all comers at 10,000, like without chest pain and whatever, because you're not going to detect a lot of disease, right? A lot of those people are normal or they have indigestion. So you really want to run your trial where you're going to see people with disease. And so that's how you set who's coming in. The age, the average age was 62 plus minus 8, and that's right in the sweet spot for where people start feeling this. Pre-procedural risk, 50%. Many, many enrolling sites. Close to 200 independent sites enroll patients for this trial. So you have a very high variance in the ability of these sites to produce good data. Don't believe that any hospital you go to, you're going to get the same quality of care. That's not true, right? It depends on the experience of the physicians at that hospital. Have they been doing this procedure for 10 years, or are they very new to it? And it turns out a lot of these centers were quite new to reading coronary CTA. Not so much SPECT and ECG stress. These have been around for 30 years. So basically, CTA is done first, SPECT in half, and then you just manage the patient and you look for the primary endpoint of death, myocardial infarction, hospitalization for unstable angina, that means coming back to the hospital, or major procedural complications. And they followed for 25 months. In this arm, they had 164 events. In this arm, they had 151, which was roughly 30% of the number they thought they were going to see, based on historical data of how the patients with this risk, normally, instead of this 300 events, they expect to see about 1,000 events, right, with this risk. The reason they didn't see 1,000 events is likely because regardless of the pathway these people went on, it was all basically highly focused on the US, all of these patients probably maxed out on statins. And that maxing out on statins is a relatively new thing and just drops the event rate, the expected event rate in patients with 50% risk. So if anything comes out of this trial, it is get your patient on statins, regardless if you do a CTA or you do a stress test, put them on a statin. And then they show a event rate as a function of time, which we'll look at, and the two curves are just identical. Okay, this is the interesting part to me, and this is why I'm presenting this paper. In the technical aspects of it, 5,000, close to 5,000 in each box go into CTA or into stress testing, right? 4,077 come out and are declared normal. Okay, remember they had a 50% rate, like risk rate, but they're normal. Now the risk rate was for events in the next 10 years, but anyway. So you get 609 people from this group were selected looking at their CTA to go to the cath lab because they had disease on the CTA. Okay. On the other side, from the stress test, 406 people were selected to go to the cath lab to either get treatment or a diagnostic cath. So already there's a big difference here, right? There's 200 people difference here. Two of my friends were in this box. They weren't in this trial, but this happened to them. They were completely abnormal, and they got called normal by a stress test and wound up over here. Okay. So now let's continue down this side. Of the 406 people that were selected to go to the cath lab using a positive stress test, who was normal and who had abnormal vessels as seen on coronary cath? And this is called the gold standard or the ground truth, right? This is the truth here. Turns out that 213 of these 406 on coronary cath were normal, which is crazy, right? That's just too many normals, because that's more than half of these patients are normal. That to me, it's not so great. 193 were found to have disease on coronary cath, and of those 193, 158 were treated. So it's a fairly high ratio of treating the people that you find abnormal in cath. Okay? They weren't just abnormal, they actually got treated with either a stent, which is PCI, or they got a CABG, which is a bypass surgery. Over here, of the 609 people that were sent to cath, 439 were found to have disease on cath. Okay, so let's pause for a second and look at this. These boxes are to scale. This many patients were positive versus this many in this arm. I've been doing imaging for a very long time, and I have never seen a division like this where one imaging technique completely blows the other one out of the water for detecting disease, right? So you have way more disease detected over here. Unfortunately, you also have some false positives. 170 people were found to be negative when they went to cath. And there's a group of patients here who were positive on cath, but they didn't treat. They just said, you know what, this disease isn't severe enough, we're just going to put you on drugs, right? Maximal drug therapy. 236 PCIs, 75 CABGs, which is twice as many as this box. So basically, down this pathway, you treated, in the end, twice as many patients. You also did 50% more caths. So, primary result, if you go into CTA first, you're going to do more caths down the line, right? Because you're going to find more disease. So the cath demand will go up. Like the demand on how many caths we have to do is going to go up, because here we only had 406. Not only that, I'm going to do 236 more stents, or 236 stents versus 120, right? So twice as many stents. So if you're a business and you're in the business of putting in stents and cathing people, this is a good thing, right? Because your business goes up. If you're an insurance company and you're insuring people, this is a bad thing because you have to pay for all this. It's like twice as expensive as this side, right? So in some ways, from the health economic standpoint, if you're the provider of care, this pathway pushes up the amount of care that you have to do. This pathway pushes it down. If you're the payer, if you're Medicare or a health insurance company, this looks like a better pathway. You do less stuff, right? And then the issue with this study now is we've treated this many on this side, this many on this side. This is far too few people to detect a difference in numbers of events, because that's the only perturbation is we treated 236 versus 120. And so the numbers just are way too small to determine whether or not this side that had the 439 people positive on cath versus 193, has a different event rate. Specifically, they only went out to, I think, where did the numbers really drop off? About 24 months, right? So it's a really interesting test, interesting study. It is a negative study in the sense that the two event rates are similar. However, this part here, along with a study that was called the Scott-Hart trial in Scotland, convinced the National Health Service in England that if somebody comes to their emergency room and they have chest pain, they don't work them up for cardiac disease. They don't do an EKG stress and hold them overnight and then do a SPECT and then do this and do that. The first thing they do is put them in a CT scanner, because basically you can eliminate the normals very rapidly, right? And so it turns out to be a cost-effective way. And they have a trial, and somebody can review this if you want, where it shows that it also, in Britain, reduced the number of heart attacks and return hospital visits. So different from this trial. So here's the two big differences from this paper. 193 positives on cath, 439 positives on cath in this CT arm versus SPECT, and then a lot more treated in this arm. However, didn't seem to make a difference. COURAGE, which is on your problem set this week, the COURAGE trial, looks directly at what happens if you give someone treatment with PCI versus giving them optimal drug therapy. And it turns out it doesn't really matter. The optimal PCI arm, the survival didn't seem to be longer than the optimal drug therapy, which was a big bombshell when that study was published. And so it's a good one to look at. Okay. All right. Any questions about that? Okay, terrific. And we'll see you on Tuesday.